Welcome back to World of Pain MD podcast. If you treat back and joint pain like I do, you become familiar with two patient goals. First, they want to feel better, and then second, they want to understand why they hurt. As an interventional physiatrist, I spent a lot of time talking about the traditional different treatment pathways, things like physical therapy, exercise, medications, chiropractic care, acupuncture, and when appropriate, injections and sometimes surgery is a part of that conversation. However, I've realized, though, that a part of this conversation that we need to talk about more is how is your sleep? I honestly can't think of anything that affects nearly every aspect of our physical and mental health more than getting good restorative sleep. And if you're not sleeping well, your body's ability to heal and your perception of pain can change dramatically. That's why I'm really excited about this episode today. Joining us today is Dr. Natalie Solomon, a licensed psychologist, board-certified in behavioral sleep medicine, and clinical associate professor of psychiatry and behavioral sciences at Stanford University School of Medicine. She specializes in research and treatment of sleep disorders, including insomnia, circadian rhythm disorders, parasomnias, and nightmares. In this episode, we introduce the fundamentals of cognitive behavioral therapy for insomnia, otherwise known as CBT-I. We really just scratch the surface, but if you struggle with sleep, or especially if you're dealing with chronic pain, I think you'll find this conversation incredibly valuable. As always, thank you so much for watching or listening to this episode. I hope you learned something and enjoy. The Pain podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatments, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information on this website or podcast. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity. Okay, episode 20 with Dr. Natalie Solomon. Thank you so much for being here. We are going over CBT-I, which we will jump into in just a little bit. But first of all, thank you for your time.
Of course. Thanks so much for having me. I'm happy to be here.
I think just to start things off, because CBT-I, which stands for Cognitive Behavioral Therapy for Insomnia, is relatively not that well known, I suppose. Could you tell us a little bit about how you got involved in it in the first place?
Yeah. So I first got interested in sleep because I was actually interested in circadian sciences. So I was interested in therapeutic applications of light, which led me to circadian sciences, which led me to sleep. And, I think sleep is really a window into everything. So if we think of our own lives, my sleep reflects anxiety, my sleep reflects work stress, my sleep reflects pain, my sleep reflects how my kids are doing. And so I really love sleep actually as a window into kind of our broader contexts and that it's quite treatable. So we'll talk more about this in a moment, but sleep is one of these things that responds pretty well to treatment. And the treatment is quite brief. And so I found that very hopeful, even sleep disruption that emerges in the context of something else.
That's a wonderful answer. That's really cool initially, too, that you were interested in that circadian sort of cycles and how it affects us, too. And I completely agree. I mean, the sleep being a sort of a window into how we're doing overall, like, I don't know if there's a better marker for that.
Mm-hmm.
So let's go ahead and just jump into it then. Can you explain what is cognitive behavioral therapy for insomnia and how it differs from what we traditionally just always talk about as sleep hygiene?
Yeah, I love this question. So sleep hygiene refers to that popular list of recommendations. We've probably all come across it in one way or another. It includes things like being mindful about caffeine and timing of exercise and things like that. That's the sleep hygiene list of recommendations. I like to tell people that in the insomnia research, sleep hygiene is typically used as the control condition, because it doesn't actually treat insomnia. So I'm not trying to say the recommendations are useless, like they are evidence-based and they can help a healthy sleeper further improve their sleep, but they will not treat insomnia. And in fact, like healthy sleepers and those with insomnia have the same number of sleep hygiene infractions, if you will. So it's not that insomnia is caused by breaking the sleep hygiene rules. CBT-I, on the other hand, stands for Cognitive Behavioral Therapy for Insomnia. So it's a short-term treatment. It typically lasts something like 6 to 8 sessions. It is a non-medication treatment, meaning no new medication is prescribed. If a person's on medications, both related and unrelated to sleep, that's not an issue, but new medications are not prescribed as a part of the treatment. And it's really about leveraging one's natural sleep systems to address symptoms of insomnia. So, specifically to help a person fall asleep with more ease and get back to sleep with more ease if it's someone who wakes up for prolonged periods of time in the night. So, CBTI is really the frontline treatment for insomnia, and at its core is quite different from sleep hygiene.
What is it? Thank you very much. That was a very helpful answer. I think very concise and to the point. What is it specifically indicated for?
Mhm. Yes, it's a great question. So, if you are having a hard time falling asleep, or a hard time staying asleep. So let's define that even better. Is this someone who, on average, it's taking more than 20 minutes to initiate sleep? Or are
Hmm.
you someone who your time awake in the night adds up to more than 20 minutes? So, if you fit either of those categories, you're experiencing some insomnia symptoms. If it's happening infrequently, it happens to all of us infrequently. To that, I would say same. But if it's happening, 3 or more times per week, so on at least half of the nights, and it's persisting for more than 3 months, then
Mhm.
that meets criteria for insomnia disorder in which CBTI is indicated. At this point, people typically ask, but what if my sleep disruption is attributed to something else? Like, I fit everything you said. I'm up in the night. It's occurring on more than half of the nights. It's persisted for more than 3 months, maybe even a few years. But I think my sleep disruption is connected to something else. And that something else could be menopause. That something else could be pain. That something else could be anxiety. And CBTI is still indicated even if the sleep disruption emerged in the context of something else. And the reason for this is that the research really demonstrates that sleep disruption can be one of the most residual symptoms. So, what I mean by that is even after successful treatment of the other thing, whether it's PTSD or nocturnal hot flashes or pain, sometimes sleep disruption persists. And so, what we take this to mean is that whether or not insomnia is occurring in the context of another comorbidity, it really warrants its own diagnosis and treatment. So you still meet criteria for insomnia, and you still deserve to get access to treatment that works, of which the front line is CBTI.
Wow, that's really, really good to know because I think that well, at least my understanding was that
Mhm.
it was a separate entity that you could only use CBTI for. That is to say,
Mhm.
it's chronic insomnia, primary chronic insomnia, not caused by something else. And so the fact that we can use it for this sort of additional residual insomnia, like you kind of spoke about, that's really good to know. Um, so why is it that CBTI is first line? Like we often, myself included, I think you would think melatonin, for
Mhm.
instance, or sort of or other oral medication or supplement would be sort of first line. That is to say, it's like CBTI for me, I didn't even know about. And
Mhm.
so, why is it that it is first line?
Yeah. I mean, I'll start by saying you're not alone. Although CBTI is the frontline and first line treatment, it's not the most commonly used treatment. So, the most
Mhm,
commonly used treatment is often medication. And
mhm,
it's for the reasons you said. Many people haven't heard of CBTI. Even if you have heard of it, getting access to treatment can be difficult. And so, for all these reasons, often people are offered medication first. So, why is it the front line? So, firstly, for supplements, things like melatonin, they are not actually indicated for insomnia. So, there's some evidence that supplements can be used in the context of sleep. However, they are not indicated as a treatment for insomnia. Then we have our prescription medications, of which there are different classes of drugs that can be used for insomnia. And research demonstrates that CBTI and medication often has similar effects in the short term. So, in the immediate aftermath of treatment, we see some similar effects of medication and CBTI. However, CBTI consistently is shown to be the more durable treatment. So, when they follow people over time, often those who are taking medication for their sleep, and some people listening may have had this experience themselves, find that it becomes less effective for them. or they need to change or increase the dose, or sometimes they're trying to change medications. And so in the longer term, often it doesn't work that well for people, as well as there are some concerns about long-term use. So many of the sleep medications we have access to now are really good under specific circumstances, like a short-term acute episode of insomnia, but they're not necessarily indicated for longer-term use. Versus CBT-I, we see this similar effects in the short term, more durable effects in the longer term without this concern of long-term use.
When we say durability, what timelines or how far out have we looked at, I suppose in the literature and your experiences, how long does the effects or results of CBT-I last?
It's a great question. So some of the very well-known studies are following people up to like 2 years. There are even much longer term studies than that, where they're looking at people 5 or 10 years post-treatment.
Mm-hmm.
I'm trying to think if there's like a consistent metric of durability. I suppose the range is anywhere from 6 months post-treatment to something like 10 years post-treatment.
Yeah, the 10-year mark, I feel like, is always sort of in my mind when you know something is at least, if we've looked into it, when you know something is actually has an effect. Because 10 years, I mean, you can't really fake that,
Yeah.
I would think.
I mean, as you know, I'm a part of this training program where we train providers in CBT-I. And something I always find kind of moving is we have providers who come to train with us who initially became interested in insomnia because they had insomnia. So this kind of happens in every cohort, that we have a provider who they themselves navigated insomnia, really saw the positive impact of CBT-I, and then wanted to offer it to other people. And that's always kind of magic to hear, someone saying, I really struggled with this 5 years ago, 10 years ago, 15 years ago, and this was really life-changing for me. It's something I want to be able to offer my patients.
So speaking of that, as if I were to come to you and I said, I'm struggling with chronic insomnia, I would like to go ahead and sign up for the CBT-I. What does that program look like? Like, what is the timeline, the patient commitment, so to speak?
It's a great question. So, as I mentioned before, it's brief. So, we tend to meet with people something like 6 to 8 times. Those meetings can be every week or every other week. And there can be flexibility, right? Like if you are going away, your provider's going away, you have a vacation, it doesn't have to be to the dot. So, it's something like 6 to 8 meetings. Those are weekly or bi weekly. Importantly, treatment is really what happens between meetings. So, what I mean by that is together, the provider and the patient collaboratively come up with a plan to improve sleep. The provider brings in kind of expertise on sleep and the CBT-I protocol, but the patient really brings in expertise on themselves and what's going to work for them and what's workable for them. So, you come up with a plan, and it's really implemented between sessions. Most people see results within the first 2 weeks. And if not, we want to troubleshoot. What's getting in the way? Is the person able to follow the plan? So when you ask, like, what does it entail? It entails things like very individualized recommendations about when to get into and out of bed. And that's adjusted week after week. It also relates to other tools to help a person kind of settle or quiet an active mind or an active nervous system. So there's some other tools to kind of help. We all know the feeling where you're sleepy, you're tired, but you're wired, right? Like an undercurrent of activation that can be very present for people who are struggling with their sleep. So it's also some tools to navigate that.
Yeah. I don't know if there's any literature or anything behind this, but I think that sometimes, now I have like an infant, often talk about how they can get overtired and then they're just sort of like tired but wired sort of scenario. I find for myself, like if I'm tired, but I'll look at my phone for 30 minutes and see a bunch of stuff that maybe gets my mind rolling, then it's like, oh, just like 30 minutes ago, I was actually tired, but now like I still am tired, but I can't seem to shut my mind off. So that really resonates with me.
Yeah, absolutely. We are big infants.
Yeah, that's a good way to put it. When we talk about CBT-I making effects on us, obviously we're looking at results and whether or not we're getting more sleep, better quality of sleep, getting to sleep faster, our efficiency of sleep is better. But does it actually make a difference in our biological systems? That is like the sleep systems. Does it make a difference in the things like the amygdala, the hypothalamus? Do we have fMRI data to show that?
Yes, I love this question. Sometimes people think of insomnia as either physical or psychological, but that's a really false distinction.
Mhm.
Insomnia is both physical and psychological. And what I mean by that is physically, a person has an opportunity to sleep but cannot. right? For
Hmm.
reasons they sometimes can't explain, they find themselves awake. And psychologically, of course, we have a response to that. That can be stressful. That can result in increased distress. And so there's as well a psychological layer as well. We might get very stressed about it, right? When we think about the effects of CBTI, you are correct. We see improvement in sleep quality. This is both subjectively and objectively measured. So, when a person is measuring their own sleep, we see an improvement. We also see improvements on objective measures of sleep.
Hmm.
We see an improvement in sleep quantity, right? So, if a person's not getting enough sleep, we see improvements both subjectively and objectively. When I think about other biological systems, there are things such as our sleep drive system. So, I could talk a lot about this, but I'll try to briefly say, sleep drive is your appetite for sleep.
Hmm.
But it's not a psychological construct. It's that as you spend more time awake, you're actually accumulating adenosine in your prefrontal cortex. So, with more wakefulness, we have more of this sleep drive. And through CBTI, we can really help a person leverage their sleep drive so that when you go to sleep, your system is very hungry for sleep. You have a strong appetite for sleep. So, biologically, one can leverage their sleep drive.
Hmm.
I could also think about the biological underpinnings of the hyperarousal system, right? So we talked about this tired but wired. What is the wired piece? The wired piece is that we are designed so that our stress response system is stronger than our sleep systems. That makes sense, right? If we were like evolving as people, if something stressful happened, I don't know, a lion walked into my cave, I should be able to respond and I probably won't even feel sleepy. Like that's very adaptive. And so, for that reason, when that stress response system is triggered, our sleep, we don't even feel sleepy, it like dissipates.
Hmm.
Except it's not a lion walking into our cave anymore. It might be like a work email.
Hmm. Yep.
Might be like having a stressful conversation. It might be these are the kinds of lines that come into our caves these days. And so it makes sense that our biological hyperarousal system, which is often measured by things like heart rate, temperature of your hands and feet,
Hmm.
strong. And so some of the tools biologically we can measure that we can decrease this response. We're not trying to get rid of it, but
Hmm.
decrease it so that a person can get back to resting
Hmm.
and address these things during the day. And then to your question specifically about fMRI, there are many fMRI studies and there are kind of reviews looking at the findings. And essentially, fMRI studies support what people were subjectively reporting. The neuroimaging results complement the behavioral measurements, including treatment efficacy, and support the effectiveness of CBTI treatment in the recovery of brain function and structure.
Wow, I think those reasons and the ability of CBTI to make such a relatively quick impact on something that could be so chronic in one's life really attracted me to this idea of what CBTI was and really interested me in more because having effects within 2 weeks of something like not being able to sleep for months, I think is probably to some people really groundbreaking and probably
Mhm.
changes the quality of their life and who they feel they are. Um, so, common misconceptions about sleep. Does CBTI help in regards of addressing those sort of things?
Yeah, there are so many myths about sleep. I find a lot of our kind of popular conversation about sleep is pretty misleading and at times harmful. So, quite a few come to mind. So, one is the 8 hour myth. The
Mm,
myth is everyone needs 8 hours of sleep. It's just
mhm,
not true. And so, it's not even an average. And so, it leads, there are people who need more sleep than that. They're
mhm,
really 9 hour sleepers. There are people whose sleep need gets met in less time than that, 6.5, 7 hours. And so, it
mhm,
really leads people down a dangerous road thinking that they need 8 hours. It's very unhelpful and very inaccurate. The other one that comes to mind is that one should sleep through the night, that, one should put their head on the pillow and remember nothing and wake up in the morning and stretch like a Disney princess. But really,
mhm,
it's quite normal to wake up in the night. The goal is for awakenings to be brief. So, if a person wakes up 3 times and they're all like 5 minutes and in total they're awake for less than 20 minutes in the night, this would actually be considered really normal and healthy. So there's also this myth about sleeping through the night.
mhm,
Um, Another one that comes to mind is kind of this social narrative around we should all be morning people.
mhm,
We say things like early bird gets the worm.
Mhm.
But really, the scientific word for this is chronotype. And
Mhm.
chronotype refers to, are you biologically more of a morning person? You feel sleepy earlier and you wake up earlier. Are you biologically a little bit more of a night owl? You're able to get energy in the evening. You're able to sleep in when given the opportunity. And, of course, life circumstance plays a role here. But in general, the best health outcomes are if a person can actually sleep in alignment with their circadian clock. So if you are a night owl and your lifestyle allows, which some
Mhm.
of us do or don't have that privilege, it's
Mhm.
not a bad idea to go to bed later and wake up later. So, I suppose the myth is like we should all be morning people or morning people are good or
Right,
good
right.
in some
Yes.
way.
Yes, that is so spot on. Those three actually kind of in prepping for this podcast, having come across those, especially the 8 hour rule,
Mm.
kind of blew my mind, and it still kind of does because I've lived by that for now, like as long as I've been alive, I guess. And so, how does one sort of know how many hours they need? I suppose.
Yeah. So, first, there's a difference between quantity and quality, right? So, if you are someone who's having awakenings in the night, you want to first address those awakenings before you can really get a sense in terms of quantity. It's hard to
Hmm.
tell, but, right? Like a fragmented 7 hours, which might be plenty of sleep, can feel quite bad. So, you address
Hmm.
quality first, and that can happen with the help of a CBTI provider. Then, in
Hmm.
terms of quantity, how much sleep is the right amount? The best indicator is actually how one feels during the day. So if you
Hmm.
are consistently getting, let's say, 7.5 hours and you largely feel not sleepy during the day, that might be a sign that your sleep need is getting met. However, if you're getting 7.5 hours and you have a strong urge to nap most afternoons, then that's a sign that perhaps you could use a little bit more sleep. So it's really, is one feeling sleepy during the day?
Hmm.
And I like to mention that sleepy is different from tired. So
Hmm.
you might feel tired during the day, meaning fatigued of mind or body or both. But you want to check in, am I feeling sleepy? Do I feel like sleep is lapping at me a little bit? Do I
Hmm.
feel like if I lay down, I might take a nap or drift off to sleep? That's a sign of sleepiness. And
Hmm.
so, we have this huge range. People need somewhere between 5.5 to 9.5. So, how do you know your individual number? One is thinking about your history. So,
Hmm.
before you struggled with your sleep, around what were your sleep hours? How much sleep would you get per night? And if you consistently get that number, what's the number that leads you to feel non sleepy during the day?
That's a wonderful answer. I do get confused a little bit because I really like coffee, and so I
Mhm.
drink a ton of coffee,
Mhm.
and sometimes I think maybe I do feel tired, and yet because of the amount of coffee that I'm drinking, it's not an outrageous number. I mean, we're not talking Denmark, Scandinavian levels, but
Mhm.
still, I feel like I might be covering up this sleepiness. Is there a way that even despite the and then more broadly, how popular energy drinks are, and there's so many different varieties nowadays. How does that come into play when we talk
Mm.
about how you feel and how much sleep you get?
Right. It's a great question because there's sleepiness, and then there's also many ways to mask sleepiness, right? Including caffeine.
Mhm.
One idea is that there's some individual variation, but the half life of caffeine is approximately 6 hours. So if you're having your last caffeinated beverage at, let's say, lunch,
Mhm.
and if you have a crash sometime around 5 or 6 p.m., it may be a sign that you had some unmet sleep need that was being covered by caffeine, kind of masked.
Mhm.
Or the opposite, if you're someone who enjoys your caffeine and as it wears off, you feel similar, then maybe it's
Mhm.
a sign that the caffeine wasn't masking an unmet sleep need.
Mhm. Interesting. So part of CBTI is actually essentially restricting sometimes that maybe when you're in bed, and then patients may feel worse during this period of time. How do you help patients through this and coach them through this sort of sleep restrictive phase?
Mm. So, yes, a part of CBTI is coming up with individualized recommendations on times into and out of bed, which
Mhm.
often includes temporarily spending less time in bed and more time out of bed so that a person can build up more of the sleep appetite so that you can get a stronger sleep. I should mention some patients do struggle with this, right? Because it's a change to your habit and you might temporarily be spending less time in bed. Some
Mhm.
patients receive relief pretty quickly. So I always stay away from these phrases like things will get worse before they get better because it's really not true for many people. Often things get better.
Mhm.
um, but for some people, it's very difficult. I mean, I know this in myself. It's hard to change habit, and it's certainly hard to change habits around your sleep, you know? So, your question is, how do we help through it? So, I think number one is we talk about the rationale. If I was a CBTI patient, I would only do it if it made sense to me. So,
Mhm.
I really want to talk to my patients about like what is the scientific rationale to this. I don't want you to do it because I said to. I want you to do it because you think it really makes sense for your sleep system.
Mhm.
Number two is I always promote a flexible approach, which is I want something that works, but is also doable for you. And so if I suggest something that a patient says, like, that just sounds really hard, I don't know if I can do that. I'm like, I always say everything's up for a debate. Let's bend it. Let's make a doable version, even if it means it's a slightly slower process. If it's workable for you, then it's workable. And the third thing I often have people reflect on is if we don't change something and we keep doing things as they are, sleep will remain as it is. And most people are suffering quite a bit. So when you're struggling with insomnia, it's quite hard on you. And so even something asked of you that's quite difficult, you're already doing the worst case scenario, which is somehow functioning and making it through on pretty compromised sleep. And so many people find their willingness to do something hard is actually increased because they're already having a hard time. You might as well have a hard time and it be moving you in the correct direction.
So it's a mind shift sometimes. You have to sort of frame your perspective in a way that allows you to better understand something that might be challenging initially, or at least appears to be challenging. But I mean, you're there because you're already going through a difficult time in the first
Right. It's
place.
challenging both ways, honestly. It's challenging to navigate insomnia and it's challenging to initiate insomnia treatment, but at least one is moving you towards your goals.
Right, right. Yeah, that applies, I think, broadly to life.
Mm.
There are obvious contraindications to medications that we prescribe individuals all the time. But I think it's less thought of that things that are like CBTI or cognitive behavioral therapies, just in general, would have contraindications. However, for CBTI, are there contraindications?
Mhm. The first contraindication that comes to mind is if you're navigating a substance use disorder. So that's not to say
Mm,
you're totally ineligible for CBTI, but it does mean that we tend to think of prioritizing substance use treatment, at least to have some kind of stabilization in sleep so that then a person can really benefit most from CBTI. There are other populations that come to mind that aren't necessarily contraindications, but you want to make sure to work with an experienced CBTI provider if you're one of these other populations. So, what these other populations are if you're a shift worker. So, if you're engaged in shift work, you can be a good candidate for CBTI. You just want to work with an experienced provider. If you have a seizure disorder, so there is some conversation around, sleep deprivation can lower the seizure threshold. And so you want to work with someone who can be very nuanced in their approach with you. And if you're engaged in some nighttime caregiving, so you mentioned before having an infant, we can work with people postpartum or who are engaged in nighttime caregiving, but you want to work with an experienced provider who can build in time for the duties that one needs to do at night. So it's a long way of saying the contraindication that comes to mind is a substance use disorder, and there are some special populations who'd want to work with an experienced provider. Oh, I should mention another special population is if you have a history of bipolar disorder
mhm.
just because you want someone who can be thoughtful about the connection of sleep and mania.
You've worked in the field of sort of women's health and pregnancy and chronic insomnia. How do those patient populations differ than your average, I guess, patient that you would see with, who is perhaps not pregnant?
Mhm. You're right. I'm really interested in this intersection of women's health and sleep. So, I'm specifically both research and clinically looking at sleep in menstruation, sleep in pregnancy, sleep in postpartum, and sleep in menopause.
Hmm.
And sleep in women's cancers. So I could say a lot about each, but I'll spare you. But the long way of saying it, or the short version, is we're so fortunate to have RCTs, so randomized control trials of CBTI for these specific populations. So really looking at how is CBTI both adapted and what are the results when we use CBTI in the context of pregnancy, postpartum, menopause, etc. And the short answer is that it is effective, but there are adaptations that we make to treatment to really help a specific population whose sleep is impacted by multiple factors.
Absolutely. And having, a baby or an infant or a child, I suppose, substantially impacts how you will go about doing that. Because if you're a primary caregiver, I mean, that's obviously going to change the priorities there, I suppose, too.
Yeah. So we think about, there's nighttime caregiving. That's when you're actually up with the baby, like feeding or
Mhm.
changing. And then baby goes to sleep. And the question is, do you sometimes struggle to get back to sleep? If the answer is no, then it's not necessarily insomnia. Then you're really navigating nighttime caregiving. And so you want to think about problem solving in that area. Like, what do you need to do to have relief or some relief from nighttime caregiving? Or is this just temporary? If the answer is yes, that even after the baby goes to sleep, a person finds themselves awake and sometimes grappling with their own sleep, then there is some sleep disruption or insomnia symptom that can be really well targeted with an individualized CBT-I.
Speaking of these sort of special patient populations, I know that your primary research and focus is within women's health and the intersection of that as well as in pregnancy. Have you come across much data about how it affects those with chronic pain?
Mm-hmm. Yeah, there's a wealth of research on chronic pain and sleep. And so maybe unsurprisingly, there's quite a strong bi-directional relationship. And many people will have a felt sense of this, which is when you're really struggling with your sleep, you may notice that your pain threshold is even lower. Your pain experience is even more acute, right? And the other way around, when you're navigating a pain flare-up or a worsening in pain, your sleep is disrupted.
Mm-hmm.
The good news is that there are RCTs of CBT-I in the context of chronic pain, and CBT-I is still effective. And sometimes people are really surprised to hear this, actually. They're like, but my sleep is only disrupted because of my pain. And that may be true. And it's still also true that a person has natural biological sleep systems that can be leveraged and sleep can be improved, even in the context of a pain profile.
That's great to hear, and sort of why I'm also here too, because the patient population I see primarily are patients with chronic pain, and it seems to me that in addition to things like your diet and exercise, the one other sort of pillar, I mean, I suppose there's other pillars, but one of the main pillars would be sleep. And I feel like that can just sort of so broadly affect so many categories in one's life. And also, it can be more attainable than you think with therapies like CBT-I, which is, I think, a little bit inspiring and why I'd like to get the word out some more. And speaking of which, in clinicians such as myself who would like to start incorporating things like CBT-I, the principles at least, into practice without formal training, how should one even go about doing that, or should they even go about doing that?
Hmm. I would say if a provider is interested in learning more about CBT-I, I would advise them to seek some formal training in it. Because of the
Mm-hmm.
reasons that we talked about before, I worry if someone just does some of their own self-learning that they'll implement it a bit like sleep hygiene. It won't
Mm-hmm.
be very effective. And in fact, patients will leave thinking, I tried that and it didn't work. So there are many places to seek CPTI training, and most trainings are open to providers from different backgrounds. So one could
Mm-hmm.
have an MD background, one could be a licensed social worker. But if you are in a position where you can provide therapeutic intervention to patients, then I absolutely encourage people to seek CPTI training. And there are not enough providers. We really have a provider shortage. There are way more people with insomnia than there are providers who can deliver treatment.
I was looking at the numbers, and it looks like, I don't know if this is correct or not. You might be able to correct me. The patient, I guess the amount of people in the United States that have chronic insomnia is estimated to be around 10%. Does that sound right, or is that off?
Yeah, in the literature we see ranges, but normally 10% is actually on the lower end. I see something like 10 to 20% of people meet criteria for insomnia. So that's a huge amount of people that this is impacting.
Yeah, that's an enormous amount. It's crazy, but it actually is not that crazy given how so wild the world is right now. Um, are there digital ways or platforms that you'd recommend, or referral pathways clinicians should know about in order to reach a CBTI professional?
Yeah. So, two parts to this answer. There are digital platforms that provide treatment.
Mhm.
The one that I would recommend is called insomniacoach.com. So,
Okay.
if you want to refer your patients to somewhere where they can seek some treatment, insomniacoach.com is free.
Hmm.
I will say that when you're not working with a kind of live provider, we still see good results, and some people struggle with engagement. And so, if someone tries the app and says it's not working for me, or I'm not a tech person in general, I'd rather work with a provider. A
Hmm.
place where one can look for a provider is CBTI.directory. It's an international directory of CBTI providers. It's hosted by Penn, University of Pennsylvania, in which they
Hmm.
gather information and provide the information about providers. So one can look for a provider at CBTI.directory. And the last thing I wanted to mention is that there is a board certification for behavioral sleep medicine. So, a provider could say they're trained in CBTI, but you might not know what their level of training is.
Hmm.
You can look for the letters DBSM after a person's name. That stands for Diplomat of Behavioral Sleep Medicine. It means a person has gone on to receive board certification. So if you fit into one of those special populations that I mentioned that you'd like to work with a more advanced provider, that's a good indicator.
That's great to know. There are, just like we had mentioned earlier, in addition to CBTI medications,
Mhm.
when someone has seen a advanced provider such as yourself or someone else, when do you decide that this might need other sort of forms of intervention, such as medications? When do you refer those patients out?
Mhm. I would say the thing I care the most about is patient preference. So if I'm
Hmm.
meeting with a patient who says, my preference right now, I don't have bandwidth for this. I just really can't come in each week. I'm in kind of an acute time in my life. My preference is medication. Absolutely, I would refer them for a medication consult. So, this huge part is patient preference. I hear the other preference as well, which is someone says, like, I just don't want to take something if I don't have to. So my
Hmm.
preference is really to address this in a non-medication route. So
Hmm.
one huge piece is patient preference. The second is timeline. So, as we touched on before, we have some medications that are really good for sleep disruption in the shorter term. And so, if
Hmm.
a person's navigating something acute, for example, examples that come to mind was like an acute family stress or cancer treatment, they may be really good candidates for medication if that's their preference. It's a very kind of time limited experience in which it's very important to them to sleep well, which is different from someone who says, I've really navigated my sleep difficulty on and off for something like 10 years. So
Hmm.
that makes a case that they may be better candidates for CBTI, or they may need a treatment that's going to offer more durable effects. I should also mention that one can engage in CBTI while taking a sleep medication. So if you're taking, let's say, Ambien, but you're still struggling with your sleep, you can engage in CBTI to address your sleep difficulty, and you can also talk to your provider about tapering in the context of CBTI. So I work with many people who first were like, let's just help you sleep better. Once their sleep is improved, they have the option to taper the medication if that's something that they would like.
It is interesting to know, and I suppose it's good, also refreshing to know, like you're not anti-medication.
Not at all.
CBTI is not anti-sleep medication because sometimes I think there's a duality or dichotomy when it comes to maybe some, at least there's a perspective out there that it seems like therapies are just either, you do sort of in-person cognitive therapies or you take the medications. But doing them both, I think, is probably just as warranted. Is that right?
Yeah, so it's absolutely, I'm absolutely not anti medication. I'm
Yeah.
really in favor of what someone's goal is. So if someone's
Yeah.
goal is to sleep well without the medication, I'm like confident we can get there. If someone's
Hmm.
like, I take this supplement, it works well for me, or I take this medication for dual purpose. Sometimes people say I'm on this medication for anxiety and sleep, and it's worked well for me. I'm like, great. So yes, you're correct. It's absolutely not binary.
And just hopping back real quickly to that digital platform
Mhm.
nowadays, because technology has really taken off. I mean, you're in California, so you know very well about Silicon Valley and all of that, and
Mhm.
how big wearables have become. Are you a proponent for wearables? What's your perspective on using things like the? I have, I suppose this is a bit of a selfish question because I have the Aura Ring. No, yeah, there's no sponsorship or anything like that. But what is your thought process
Yeah, I
behind?
love this question. I'm sitting in Silicon Valley as we speak. Well, I
Yes.
think there's a lot of individual variation. Some people find that the wearable really helps them with behavior change. So let's
Mhm.
say, for example, you're someone who generally sleeps well, but it's hard to get enough time to sleep. Some
Mhm.
people find that kind of tracking their data in and of themselves helps them prioritize sleep more. It helps them think like, I'm going to try get a little bit more sleep on this night because it's been curtailed this last week. So
Mhm.
some people find it very helpful. There are other people who find that it actually increases their anxiety about sleep, right? So they're struggling with their sleep and they look at their wearable in the morning and it says, yeah, you had a hard night. And they
Mm.
find it kind of worsens their experience. They think like it feels more catastrophic, like, oh no, it says I'm not getting enough deep sleep. I'm not likely to feel good today. And so it's actually leading them away from helpful behavior and more towards catastrophizing or being stressed about sleep. I should also mention that the wearables are better at some metrics than others. So, kind of broadly speaking, the consumer grade wearables are quite good at total sleep time and time into and out of bed, but they really struggle with time awake in the night and sleep architecture. So, if one's
Mm.
primary concern is the wearable says something about your deep sleep, that's really the metric that they struggle the most with, just based on the data they're able to gather, which is usually body temperature, heart rate, light, and movement. However, if someone's concern is, I want to try go to bed slightly earlier, then the wearable would be pretty good at tracking that. So
Mhm.
it's a long way of saying it really depends on what you're looking for in your own relationship to it. Um, there's one last piece I wanted to mention, which is just like nutrition, right? Like attending to our nutrition is a good thing. And we can become overly attentive in a way that can harm us. Sleep is like that. Attending to our sleep is a good thing. And one can become overly attentive in a way that actually leads them down a road that's not very
Mhm.
helpful to them. And the wearables can certainly play a role in that. And then the last piece is there is this nice study in which people received feedback from their wearable about their sleep. And then we saw how it impacted their day. What the research participants did not know at the time is that the feedback that they received was not true. So it wasn't
Mhm.
actually based on their sleep. So it said things like, you didn't sleep that well last night, you didn't get enough deep sleep. It
Mhm.
really impacted how people felt during the day. They reported
Mhm.
worsened fatigue, worsened functioning, worsened mood. And so when we take that finding in as well, I trust that our consumer grade wearables are not giving us sham feedback. So I'm
Mhm.
not
Mhm.
doubting their accuracy, that it actually is our bio data. At the same time, we should just be aware that it does very much impact how we feel during the day, the feedback that we receive.
Yeah, that is so true. Um, I completely agree with that, given that I can actually track this data now as well. And it also is an interesting thing, too, because it doesn't know what you necessarily need in terms of duration of sleep, like you had pointed out earlier. So it may say you had a rough night because you only slept for 6 hours or 5.5 hours, but to you, you feel great. And if it tells you that you don't feel great because of, well, maybe it's not telling you don't feel great, but it's saying that you had a rough night, that might subsequently impact you. Is that right?
That is right. Yeah, that is right. So it's, it doesn't have the ability to be quite so individualized. It's
Yeah.
kind of offering you some data. And yeah, it's hard to figure out. I don't think there's any one right answer. I'm a data
Yeah.
person myself. I love data. And so there's a part of me that just is very attracted to the idea of quantifying these things and graphing them. And I think we have to be very aware of the way it can sit with the individual because I've certainly met people, I'm biased because I meet people with insomnia, but
Yeah.
I've met a
Right.
lot of people who their wearables have worsened things for them.
Yeah. Yeah. Especially those that, like you had pointed out earlier, I suppose the night owls or people that have their circadian rhythm set slightly differently than what we'd consider average or a morning person, too. I imagine that may negatively impact them, or I suppose even shift workers, too.
Absolutely. Whatever your circumstances, if you're navigating something with your sleep and you're constantly getting feedback, but not necessarily intervention, right? The wearables won't tell you what to do. They'll just tell
Mhm.
you when they think they're detecting something amiss. It can be quite stressful. And as we all know, increasing stress can worsen our sleep.
Two last questions here to end it. So, if you could fix one thing about how society approaches sleep, what would it be?
I love this question. Okay, what's coming to mind for me is something called sleep effort. So,
Mhm.
sleep effort refers to trying very hard to make yourself sleep. And the harder you try to make yourself sleep, the more it backfires, right? Because you can be putting in so much effort that
Mhm.
actually you're in a very effortful state, which is very sleep incompatible. And so, I often find there are very effective things a person can do to improve their sleep, but it is not laying there and trying to force yourself to sleep. So, if at any point, myself included, one finds themselves unable to sleep, my best recommendation would be to stop trying, to actually do something relaxing until sleep comes to you. You don't need to chase it around, it doesn't work anyway.
Mhm. Yeah, I think you just answered my second question, which would
Mm,
be there's one habit that we could change about sleep, what would be the biggest return on investment with change of one habit.
Mm.
But I think that's
I
exactly
think
it.
you're right. I think that probably is it. That's probably the biggest return on your investment is if you're struggling with your sleep. I
Yeah.
would say two things. Number one is do not chase sleep around. Rather, accept that you're awake and do something restful until sleep comes to you.
Mhm.
And two is maybe to notice if you are casting too wide of a net for sleep. So, what I mean by that is when one is struggling with their sleep, it makes a lot of sense that they go to bed earlier if they can, sleep in later if they can, nap if they can, right? You're struggling with your sleep. And yet the net for sleep can get quite wide. And so it may
Mhm.
actually be helpful to, again, it's a little bit counterintuitive, but it may actually be helpful to limit your sleep opportunity temporarily. And you can do that with the help of a professional so that you have more time to build up that sleep appetite. So you start sleeping better, essentially.
Wonderful. Well, I think that is an excellent place to end it. Again, thank you so much for your time. This was a wonderful conversation.
Thanks so much for having me.